Kottayam, and our senior most professor Dr. Srinivasan sir for Pondicherry, and Purushottam sir, and all the seniors, IAP members, and postgraduate students. First of all, I request all the PGs to mute all your videos and audio when the academic session is going on, because last time we find a lot of noises from the PG students who are unmuted from their side, and they are making a lot of noises. So I humbly request all the PG students to mute your audio while the academic session throughout the period. And once again, I congratulate IAP Kottayam and IC Kottayam that taken the leadership to organize today the academic feast by Dr. Virendra Kumar sir. And again, I congratulate Dr. Shanavas sir and team. The coordinating the every day, every Thursday, the academic sections are very much appreciated by their members, and all the postgraduate students are very much useful for this academic events by the IAP Kerala. I wish you all the best program. Over to Dr. Suresh for further proceedings.
So Shanavas sir for your remarks. Over to Shanavas sir.
Okay, good evening to all, respected Joe sir and senior faculty members and the IAP members of Kottayam branch and my dear friends. So at the outset, I express all the best for the program. And okay, so there is some in reference. Okay, so we can, I think, nothing more to add. So all the best for the program. Thank you.
Thank you, sir. Thank you, sir. Darling madam, our mentor for today's session. And HOD ICH Kottayam, Pediatrics ICH Kottayam. Darling madam, over to you.
Yes, respected Dr. Jose, State IAP President, senior members of the faculty like Srinivasan sir, Purushottam sir, then Shanavas sir, today's leading faculty, VK sir, and all the people who have joined in the Zoom platform. I'm happy that this program is done by my dear colleague, Dr. Virendra Kumar, and Mamda is my dear student. So I wish both of them all success, and wish that it will be an excellent session, discussion, everything. And Purushottam sir will be giving finally the comments also. Thank you, sir. All the best.
So thank you, madam. Thank you, madam. Our today's faculty is Virendra Kumar sir. Sir was a retired professor from ICH Kottayam, and now sir is working as the HOD at Travancore Medicity, Kollam. Sir is a very lovely and wonderful teacher in the sense very soft spoken and down to earth, and can go to any extent in teaching our postgraduates. And when I was the student, I also remember the good days working along with him, even taking duties along with him. So sir is a wonderful person and a very, very good teacher, soft-spoken person. And again, I welcome you, sir, to this program. I also wish all the very best to our Mamda, who is going to present the case. Over to you, Virendra Kumar sir. Kindly take over the session for the further proceedings.
Good day, everybody. Thanks, Dr. Darley, Dr. Suresh Vadakadam for the kind words. Thank you very much. First of all, respected IAP President Dr. Jose, Dr. Shanavas sir for giving me this opportunity to chair the session in the PG club. This is a very good club for the PGs doing in all districts in Kerala. It's very good, excellent. And also my pranams to Purushottam sir and Srinivasan sir and all senior faculties. My pranams. So we will go to the class. I shall try to make it as friendly and as useful for the PGs. Thank you. Over to Mamada. We will start. Mamada can share the PPT.
Mamada, you unmute yourself.
Yes, madam. Yes, madam.
Make it full screen, Mamata. Full screen.
The presentation mode. Slideshow mode.
Slide from. Yes.
Yes.
Okay,
Slides
sir.
are visible, Mota. Slides are visible. Okay, slides are visible.
Good evening, everyone. Today I'm going to present a case of 5-month-old boy baby. Date of birth on 26th of February 2023 and date of admission on 20th of July 2023. With the chief complaints of cough and fever, with 2 episodes for the last 1 month and an instantly detected abnormal particles. History of presenting illness: 5-month-old baby, boy baby with the complaints of cough, wet sound, which is a wet sounding cough, no diurnal variation, and fever, which was a low-grade fever for 2 days associated with the rhinitis. Child got admitted in local hospital on 20th of June, which is managed with the oral antibiotics and nebulizers. No history of any fast breathing or increased work of breathing or poor feeding. Subsided within 1 day, and cough intensity also reduced. Since child improved symptomatically, child was discharged on 25th of June 2023. At that time, history of upper respiratory infection for the family, for the grandmother was there. Baby again developed a cough, fever since 7th of July 2023. Fever.
Mamata is not audible.
Feverless, baby was active during the feverless period. Cough.
Mamata voice is not audible. Intermittent. Mamata not audible.
രഞ്ജിത്തിനൊന്ന് ചെക്ക് ചെയ്യുക എന്തൊക്കെ. Mamta, it is not audible. Can you go back and start from the beginning? It was not audible initially. Go from the presenting complaints first slide onwards. Your restart. It's not audible.
Hello. Sir, hello.
Yes. Now it is audible. But the second slide, yes. Okay, history of the present illness, intermittently only that was audible.
Hello.
You are audible now.
Sir, hello.
Yes. Now audible. Now audible. You restart this second slide. History of present illness.
From here. Okay, sir. Okay.
Yes.
5-month-old boy baby with a complaint. With complaints of cough, wet sounding cough, no diurnal variation and no diurnal variation, and fever, which is a low grade fever for 2 days associated with rhinitis. Child got admitted in local hospital on 20th of June, managed with oral antibiotics and nebulization. No history of fast breathing or increased work of breathing or poor feeding at that time. Fever subsided within 1 day and cough intensity also reduced. Since child improved symptomatically, child was discharged on 25th of June 2023, and at that time history of AURI was there for the grandmother, and baby again developed a cough and fever since 7th of July, and fever was low grade fever which is relieved with medication, and baby was active during the feverless period. Cough was wet sounding cough, no diurnal variation, not associated with any post-acid vomiting, not associated with noisy breathing, not associated with rhinitis. Breathlessness was there for 1 day, and mother noticed fast breathing, not associated with any feeding difficulty. consulted local hospital on 7th of July, admitted there and treated with IV antibiotics. Fever and breathlessness settled within 48 hours and cough intensity also reduced. Baby got discharged on 13th of July. It's after 7 days of admission with oral medication. On 18th of July, again consulted for the hospital for review, noticed to have an abnormal heart sounds, investigated with ECG, echo, and report told us abnormal.
Mamata, we will stop here. We will discuss the presenting complaints.
Otherwise,
Presenting complaints we will discuss. What is your interpretation about the presenting complaints before reference? There are two respiratory symptoms, 20th to 20th July to 25th July, for which the child was admitted and given nebulization also. And there is a 12 days completely asymptomatic, 12 days. Then again from 7th to 13th, again admitted and treated with antibiotics. Low grade fever, productive cough. Second time breathlessness also noticed.
yes.
So what is your interpretation? How will you analyze the presenting complaints?
Sir, otherwise normal till 4 month old, present with the 2 episodes of lower respiratory infections. First one was associated with rhinitis. So most probably it will be a viral infection mostly, and associated with low grade fever was only there. For which child was admitted for nebulization, and also family history of AURI was also there. So most probably first one will be was a viral infections mostly, and after 12 days of well-being, child again had a respiratory infection. That is over 2 weeks, child had 2 respiratory tract infections. And at the second time, child had breathlessness also. Mother noticed fast breathing, and from the hospital, they have told to mother like child have an infection for which IV antibiotics is needed. So
You think it's a recurrent respiratory infection? Recurrent respiratory infection.
Recurrent respiratory infection.
What is the respiratory infection? Is it an airway disease? Is it a parenchymal disease? Is it a pleural disease? Interstitial disease? What is your interpretation?
Sir, cough was the initial complaints, and in initial one is like cough was the initial symptom. Initially airway, sir. So initially airway will get involved, followed by during the second episode, child had breathlessness also. So in that case, mostly parenchyma involvement is also there, along with fever. Initially an airway followed by a parenchyma involvement.
Okay. Initially, you are thinking of a viral infection. Second, hello, Mamata, not audible. Hello.
Hello, sir.
What is your diagnosis about the first infection? Hello. Hello, Mamata. I think Mamata is from mobile phone.
രണ്ട് മ്യൂട്ടഡ് ആയി പോയിട്ടുണ്ട്.
Hello, sir.
Hello. Okay.
Hello, sir.
Mamata, you're.
Hello, sir.
Yes. Audible now.
Yes, sir. Sir, first infection is associated with the rhinitis. So So, it's most probably it will be viral infection only.
Yes.
And child also have a low grade fever or short day duration and treated with nebulization. And second one is associated with the increased fast breathing. So most probably it involves a parenchyma.
Okay. What are the conditions you will think of when there are two respiratory infections very close together at a 12 days gap?
It can be recurrent
Is it an
respiratory.
abnormal host?
Yes, sir. Yes, sir. It can be.
What are the possibilities?
Sir, if there is
What host is abnormal?
sir, it can be due to a congenital heart disease. Making
Cardiopulmonary. Okay. Then
it can be a immunodeficiency.
yes.
It can be a abnormal congenital like anatomical lesions can.
Airway, bronchopulmonary anomalies.
Yes, it can be
Yes.
malformation. It can be foreign body also. If there is any
5 months. 5 months. 5 months. Only. Foreign body is less likely. But what thing? What can be possible? Aspirations possible? Is aspirations?
Yes, yes.
Yes. Then. Hello.
Hello, sir.
Okay. Yes. Continue. Your continue PPT.
Otherwise, no history of any feeding difficulty, forehead sweating, or success.
Cystic fibrosis, dyskinetic cilia, they are also possible. Recurrent infections.
No history of any feeding difficulty, forehead sweating, success cycle. No history of any poor weight gain or irritability. No history of any abdominal distension. No history of any edema.
Can you show the PPT? Can you show the PPT? PPT is not visible. You have to share the screen again. Yes, now it is visible.
No history of any feeding difficulties, forehead sweating, success cycle. No history of any.
Okay, what is the importance? No history of feeding difficulty, forehead setting, suck cycle.
Everything as a part of a congenital heart disease.
Congenital heart disease or something else, more specific. What is the problem in the congenital heart disease?
A failure in failure. Heart disease is failure.
Yes.
No history of any poor weight gain. No history of any irritability. No history of any
What it signifies?
poor weight gain also. Usually in period, cardiac failure will manifest as a failure to weight gain and irritability.
Cardiac failure, congenital heart diseases, significant congenital heart diseases will have poor weight gain. Cystic fibrosis will have poor weight gain. Immunodeficiency will have poor weight gain. Yes.
No history of any abdominal distension or edema. No history of any.
Abdominal distension for what?
That is also a part of failure and like edema will be
failure, abdominal distension, which will produce abdominal distension.
Usually, it's a part of.
Yeah, that is not an important negative history. Okay, then edema over the legs. Which cardiac failure present as edema of the legs?
Usually, a dependent edema
Less
is
common. Edema of the legs are not common presentation of cardiac failure in infancy.
No history of any cyanosis. No history of any seizure or any
Cyanosis means cyanosis. Why?
Whether the child is having a cyanotic heart disease.
High flow cyanotic diseases. Okay, then.
No history of any seizure or abnormal movements. No
Will
history.
interstitial lung diseases produce cyanosis?
Interstitial lung disease can also produce cyanosis. Yes, sir.
Yes.
No history of any abnormal movement disorder, movement or seizure activity. No history of any.
Hey, what is the importance of movement disorder and seizure now
Sir,
with the presenting complaints? Importance of movement disorder and seizure with the presenting complaints.
it can be a part of any metabolic conditions also at this age. So, movement disorder, any abnormal movements of seizure can be part like
Metabolic condition means the breathlessness is metabolic acidosis. You are thinking.
no, sir. Something abnormal heart sounds is.
Will metabolic problem will produce cough?
No, sir.
Tachypnea due to metabolic, will it produce cough? Is it
No, no,
was
sir.
cough as the presenting symptom?
No, sir. Cough.
Okay, it is also not important. Abdominal distension is not important, not necessary. Movement disorders are not necessary now with the presenting complaints.
And,
Okay.
the last one also no history of any abnormal.
Okay, that also is not important with the presenting complaints. Here you have not interpreted about the respiratory infection in the family. You said there is a respiratory infection in the family.
Yes, sir.
Can it be some complication? Second, it can be a complication of the first disease. There is a respiratory infection. Grandmother has cold.
Yes, sir.
Can
Just
it
the cold.
precipitate the infection?
Bronchiolitis can
First
be.
is a viral infection, agreed, because grandmother has a cold. Second, is it a complication of the first infection?
Is a superimposed bacterial infection on the setting of the viral.
Superimposed bacterial infection, which all viral infections can predispose to bacterial infections? Which viral infections will have superimposed bacterial infections? Viral infections, superimposed bacterial infections are very rare. Which viral infections can superimpose bacterial infections?
Measles.
Measles, yes, very good. Measles, then now epidemic is there.
H1 and
Influenza, H1N1, influenza A, then varicella, HIV, pertussis. Okay. Then can it be some complication of the viral illness? Superadded bacterial pneumonia, but 12 days after the first, there is a very normal gap of 12 days. Say superadded bacterial pneumonia, will it occurs after a normalcy of 12 days? That is unlikely. Then something else, any other complication? Initial viral infection, some other complication? Especially you said there is a cardiac problem.
myocarditis.
Myocarditis, yes. Okay, then you have to add in the history of the presenting complaints any rashes you can add.
Rash.
Which virus usually produces myocarditis?
Myocarditis. Epstein-Barr virus. Coxsackie virus.
Coxsackie virus. So rashes. Okay. Adenovirus also. Yes. Yes, continue.
Coming to past history. Past history. Otherwise, no history of any other hospital admission or recurrent illness for the child. Antenatal, natal and postnatal history. The first child of non-consanguineous marriage. Spontaneous conception. Antenatal care at Medical College Hospital, Kottayam. First trimester, no history of any hyperemesis, fever, rash, urinary tract infection, exposure, drug intake or spotting. Scan was normal. Folic acid taken after confirmation of pregnancy. Second trimester, quickening felt at 5th month.
Wait, 1 minute. Anomaly scan is normal. Okay. Is it congenital heart disease? Is it possible? Anomaly scan is normal.
It can be normal. Yes, sir. Yes.
Which congenital? Suppose the anomaly scan is done by an expert less likely to miss a cardiac problem. Which all heart diseases can miss? Not miss. Actually, it is not miss, which is normal in the intrauterine period, but abnormal if persistent in the extrauterine period. If you are suspecting a congenital heart disease. Other PGs also can answer. Anshad, Gauri, Ashwati.
PDA. PDA.
PDA, yes, PDA. That is normal in the antenatal period, but if persistent, it can be abnormal. Okay. Yes, continue.
Third trimester, fetal movements well appreciated. No history of any gestational diabetes mellitus, gestational hypertension, medium PV, urinary tract infection, vaginal infection. Weight gain is 10 kg. Growth scan is small. Natal history, full term cesarean section for meconium stained amniotic fluid. Right soon after birth. Birth weight 3.230 kg. Date of birth 25th of February 2023. No history of any NAC stay. Breastfed within an hour. Developmental history, gross motor, partial head control attained at 2 to 3 months of age. That means baby need a support over neck at wobbling of head is present at present. So development
Is the
position
EQ correct?
60%.
60% needs support. 5-month baby. 5 month. Am I correct? 5-month baby
5-month baby
needs a support for the neck. Is it 60%? DQ.
partial.
DQ you can confirm in the developmental assessment, but in history wise, is it 60%? Need support means which stage of head control or which grade of head control the child has attained as per the Trivandrum CDC chart. Trivandrum CDC grading of the head control. Which grade it has attained? Grade 1 or 2 only. That means 1 to 2, 4 weeks to 8 weeks only. That means it is 35
to 40.
35%. It's a little more than less than 60%. Yes. Yes, continue.
Fine motor by dexter speech by 4 months. Social smell by 2 months and mother regard by 4 months. Language, cooing present and laugh aloud was there. Child will all other domains to normal, and child will turn head to noise and look to mother's face when she is talking. And the child is able to look on colorful toys. Vision and hearing is normal. Diet history on explicit.
Before the diet history, what is your interpretation about the development history?
Child having isolated gross motor delays there.
Yes. Gross motor delay, social language milestones, hearing and vision appears normal in the history wise. So what are the possibilities? Isolated gross motor delay.
Isolated gross motor delay, it can be a part of if there is the underlying illness like heart disease, usually the motor milestones will get affected.
Heart disease, motor milestones to delay, there should be recurrent cardiac failure. That history is not there. That much recurrence is not there. Just 1 month back, one episode of tachypnea. There is no short crust cycle, like no forehead sweating.
If there is any muscle pathology like myopathy, like that, we will get.
Before jumping into muscle pathology, which group of disorders you will think of when there is a motor delay, isolated motor delay? Is it a central disorder or a peripheral motor unit disorder?
Oh, so it's a peripheral
disorder. It's central disorder, there will be some involvement of the cognitive milestones. It is a more peripheral disorder. Peripheral disorder, which are the parts? Is it an anterior horn cell disorder? It is a root disorder or nerve disorder, myoneural junction or micelle?
It will be
5 months. 5 months.
5 months at the level of muscle Actually, we have to assess, more.
Okay, we have to assess in the examination, but what are possible? Anterior horn cell disease, is it possible? Spinal muscular atrophy.
Spinal muscular atrophy is possible, and anterior horn cell.
Okay, which is spinal muscular atrophy?
Uh,
Onset below 6 months.
Also below 6 months. 2.
2 or 1? 1 or 2?
Type 2.
Type 2. Type 2 is late in infancy, after 6 months, usually by 1.5 years. After 6 months. It is, if SMA, it is type 1, but we have to examine what all things we have to examine in SMA, if it is SMA.
Fasciculations, tongue fasciculation.
Tongue fasciculation, yes.
Then any.
Only neck weakness. You said fine motor is normal as per the history. Usually limb also will be significantly affected in type 1 SMA.
Respiratory muscles movement. SMA.
Then anterior horn cell, anterior root or nerve.
Root or nerve, usually distal part is nerve pathology. Usually distal weakness is more
Nerve distal weakness is more, and they are less common. 5 months congenital Guillain-Barré, congenital sensory neuropathies or hypomyelinating neuropathy. They are very rare diseases. Common is anterior horn cell. Then is it myoneural junction disease? Congenital myasthenia. What is your type? What is the type of illness? It is a fluctuating illness and presentation is earlier. Then which is more possible, muscle or SMA?
SMA can be considered.
There's a cardiac involvement, muscle or SMA?
SMA has the
cardiac involvement.
Muscle along.
Yes.
Along with the cardiac involvement, muscle will be more.
Okay. Which are the muscle diseases that can present at 5 months? Muscle diseases that can present this way. Is it a congenital myopathy? Give clue. Congenital muscular dystrophy, myotonic dystrophy, inflammatory muscle diseases. Metabolic muscle diseases. Which one?
Congenital myopathy is one more common.
Congenital myopathy is. What are the congenital myopathies?
Nemaline.
Yes. Nemaline road myopathy. Clue is CMCN. CMCN. C is congenital muscle fiber disproportion. M is myotubular myopathy. Again, one more C, central core disease, Nemaline road myopathy. Yes. But cardiac involvement, is it myopathy is earlier or late?
No, it will be late.
Not early, not early. It is late. Which congenital myopathy has cardiac involvement? Among CMCN. Myotubular myopathy. Myotubular myopathy. Yes. Then, is it myotonic dystrophy? Congenital myotonic dystrophy.
It can be. So usually consider myotonic dystrophy of late presentation time, like 5 months of age.
It should be more severe by this time. Congenital myotonic dystrophy presenting earlier by 5 months, it should be more severe. Okay, then cardiac involvement, structural myocardial lesions are less in congenital muscular dystrophy. In congenital muscular myotonic dystrophy, in myotonic dystrophy, it is rhythm anomalies, conduction anomalies. Mainly it is conduction anomalies. Okay. Then congenital muscular dystrophy. Or which myocardial disease, which myopathy you will think of in this condition?
Dilate cardiomyopathy.
Which muscle disease you are thinking of? Srinivasans are saying SMA will be detected earlier. Definitely, SMA should have manifestations earlier. Feeding difficulties and respiratory involvement. SMA type 1 should have more.
Especially in Kerala, where all that well-trained doctors.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Then which myopathy is possible? Is it inflammatory myopathy? There is a viral infection, myocarditis, and muscle. Can it be inflammatory myopathy?
Yes.
In the examination, we have to deal with clearly identify, but examination and investigation. Some of them we cannot say by clinically. Then can it be metabolic? Hello, Mamata?
Metabolic.
Which metabolic? Which are the metabolic myopathies?
It can be a periodic.
Periodic paralysis is again intermittent. As myasthenia, it is intermittent. Which metabolic myopathies?
Actually, Pombies can.
Carbohydrate metabolism. Yes, glycogen storage disease. Okay. Yes, Pombies. Any other carbohydrate metabolism which can present like Pompe, which previously it was called glycogen storage disease 2B. Now it is a separate illness. 2A is Pompe, 2B is some other illness. Now it is separated. 2 is Pompe. What is that? Especially more severe in male. This is a boy. Male infant. Females will have later presentation. Males will have a earlier presentation, but not early as 5 months. Which one? Danon disease. Danon disease. That is another glycogen storage disease.
LAMP.
Enzyme is different. That is due to a lysosomal membrane protein anomaly, not enzyme. Okay, Danon. Then any other metabolic other than glycogen storage?
Like.
Any lipid storage? Fatty acid oxidation defects, can it affect the muscles? Can it affect the heart? Fatty acid oxidation defects.
Fatty acid oxidation defect can be affected.
What is the presentation?
Mitochondrial disease can also.
Yes, mitochondrial diseases. How will you differentiate this? How will you analyze mitochondrial fatty acid? What is the presentation? It's not just muscle and heart alone. Fatty acid will present as hypoglycemia and Reye-like manifestations, Reye syndrome-like manifestations. Then mitochondrial disease is a
usually affecting heart, muscle.
Multi-system disorder. It affects the brain, it affects the retina, it affects the heart, it affects the muscle, it affects the kidneys, pancreas, where all metabolism is a mitochondrial disease. It is a multi-system disorder. Here only muscles and heart. Yes. So what are the final? Then Fabry's disease, another lipid storage disease. Fabry's, that also will affect heart muscles. Presentation is later presentation. 2 years, 5 months is earlier, and there will be severe paresthesia, pain in the extremities, and also later there will be skin rashes and angiokeratomas. Okay, so finally, what is your interpretation? Finally, is it a muscle disease or SMA?
Since a cardiac involvement is also there, most probably
muscle disease, isn't it? Or SMA, which one? Not
Muscle-
audible.
Muscle disease. Muscle
Ashwati,
disease.
Ashwati, you can answer. Ashwati Sunil. Anshad, Gauri, anybody can answer.
Muscle disease, sir.
Is it SMA or is it a muscle disease? If
Muscle
muscle
disease,
disease,
sir.
which muscle disease? Most probable from the history.
Likely to be metabolic muscle disease, metabolic myopathy.
Yes, muscle disease, metabolic myopathy. SMA will be presentation. By this time, type 1, SMA type 1 should be more severely affected. Just head control, gross motor delay alone will not be the presentation. It will be more. But we have to see the examination findings. There will be difference in the examination findings between SMA and myopathy. We can clearly differentiate. Among the myopathies, metabolic myopathy you think of, also inflammatory myopathies, but inflammatory myopathies are less common in infancy. Older children it is common, and also that illness is not that severe. As Srinivasan sir saying, carnitine deficiency. Carnitine deficiency is another lipid metabolic problem that can produce myopathies. Yes, metabolic myopathies. Okay. Yes, continue.
Diet history on exclusive breastfeeding. Feeds every 3 hourly now. Night feeds also there. No difficulty or change in feeding behavior.
Okay, diet history is normal. Oh, yes, yes, you can continue.
Immunization history, BCG, OPV,
Fully immunized? Is it fully immunized according to the national schedule?
fully immunized.
Universal immunization protocol?
Yes, 314.
Yes, you can skip that slide.
Family history, no significant family history of suggestive of any developmental delay, cardiac illness, sudden cardiac death, or neonatal death.
Okay, yes. No cardiac illness, yes, yes.
Summary of the history. As a 5-month-old baby boy, the firstborn of non-consanguineous marriage, with isolated gross motor delay, normal training baby, with history of LRTA, now admitted for incidental detected abnormal heart count. It is there is no significant family history of the cardiac illness or developmental delay. So it is probably a disease causing muscle and like heart. Probably a heart disease along with the muscle, like multi-system, something which causing a multi-system involvement.
No significant family history of cardiac illness, developmental delay. Yes. So, okay, what is your probability?
Since it affect development, like isolated motor delay, and like some cardiac pathology is also there, something which affecting both the systems, right? Metabolic conditions can affect both the systems. So most probably a metabolic condition.
Acyanotic heart disease, is it a what are the acyanotic heart diseases? Which heart disease is possible?
Shunt deletions.
Shunt deletion, then? After the examination, you have interpreted the developmental history also. Still shunt deletion? Shunt deletion can be possible, but we have to examine. Then myocardial disease also is possible. Cardiomyopathy is also possible because of your developmental assessment is developmental history suggestive of a muscle problem, myopathy. So we have to think of myocardial disease also, not a shunt deletion alone. Need not be a congenital heart disease. Okay. Since you are suspecting metabolic myopathies, is your family history sufficient? Your previous side, family history, is it sufficient? Metabolic myopathy.
Non-Stephanie developmental delay, non-Stephanie.
What is important while presenting a PG case, PG examination? What is important in the family history in this check? Because there is a developmental history abnormality which you are suspecting a metabolic disease, metabolic myopathy. Then what is the important in the family history? What chart is important? Clue. Pedigree chart. 3. What pedigree chart? Specifically, 3 generation pedigree chart. 3 generation pedigree chart. That is important. If you draw the 3 generation pedigree chart, you will get additional examination marks, additional marks in the examination. So that is a very important. 3 generation pedigree chart. Okay. Yes, continue. We'll go with the examination.
On examination, alert and playful. No pallor, no ictus, no sinuses, clubbing, heart rate of 120. BP was 98/56 and lower limit was 94/56. Respiratory of 30, temperature 94/6 degree Fahrenheit.
Wait. Upper limb BP, lower limb BP. What is your interpretation?
Lower limb BP
It is normally high.
should be normally high. Very low, but all the peripheral pulsations are equally felt. Lower limb
Okay. Upper limb BP is expected to be, lower limb BP is expected to be higher than upper limb BP, but the difference is very small. Okay. Maybe an error. Maybe an error. Okay. Provided the pulsations in the upper limb and lower limb are equal, is normal pulsations, no difference. Okay.
Saturation,
Yes.
saturation 98.
But we will keep it in mind. Any abnormality in the pulse examination? Have you described the pulse in detail?
Heart rate of normal volume, normal with no brachioradial.
Okay. That's not complete because it is a cardiovascular system. So you have to complete the pulse rate, rhythm, volume, character, everything you have to write in a radial or radiofemoral difference that you have to mention. Many diseases you can pick up by that. Many of the metabolic diseases have arteriopathies also. Yes.
Head to foot examination. This one is the picture of baby. Head appears normal in size. With no facial dysmorphism. Eyes normally set. No epicanthal fold or no ears are normally set. No facial dysmorphism. Chest and abdomen is normal. Upper extremities are normal. Then lower extremities, there is an overriding of toes present.
No. In the faces, in the that photo, that photo of the child, what is the anomaly in the face? Anything you see? What about the mouth? What about the mouth? It is a upper lip is inverted V. Tended mouth. Tongue seems to be a little protruded. Nasolabial folds are clear, not clear. Then what is the posture of the baby? 5-month-old baby, is this the posture?
Posture hypotonic posture.
It's a hypotonic posture and also a myopathic facies. Tended upper lip, tongue seems protruded, nasolabial folds are not clearly seen. I don't think is it due to the photo, but seems to be has a myopathic facies and also upper limb posture is a hypotonic posture. Fine motor may not be normal.
He is able to guide us to see. Able to hold.
Yes, we will see the assessment. Now, what is the anomaly in the leg?
Overriding of toes are there.
What are the conditions producing overriding of the toes?
All the trisomy can have
Why?
adverse.
Why there is overriding? What are the arches in the foot? Two longitudinal arches.
Medial longitudinal arch and lateral longitudinal arch. Medial longitudinal arch and lateral longitudinal arch. And there is a transverse anterior arch.
Two longitudinal arches, lateral and medial longitudinal arches, and one anterior transverse arch. There will be a symmetrical pull of the muscles, small muscles of the foot, or due to the ligaments. Many genetic conditions will have this. And also, it can be environmental also. Yes. That but crease will be due to the overriding of the fingers. Seems to be a forefoot adduction. Seems to be. Is it due to the pressure or not? We don't know. I am not sure. Yes. Yes, clinodactyly is, as Srinivasan sir is saying, there is clinodactyly of the little toe. That is overriding. Yes. And sir is commenting about the Srinivasan sir is commenting about hypertelorism, epicandal fold. I think you have examined the eyes are masked for the presentation because we cannot present with a full face. That is why eyes are masked. You have, hope you have examined. There is no hypertelorism, no epicandal fold. That is not clear by this view. What is clinodactyly of the finger?
Clinodactyly is the midphalangeal hypoplasia.
Pardon? Not heard well.
Clinodactyly is the abnormally bent.
What is clinodactyly?
Abnormal bend.
Yes. Abnormal bend. Due to what? Any other PG? Any other resident? Anshad, Gauri, Ashwati, anybody? What is clinodactyly?
Which finger you will see? Which finger?
Abnormal bending, either deviation due to hypoplasia of the proximal phalanx.
Which finger? Sir is asking which finger?
Fifth finger, fifth.
Little finger.
Yeah.
Okay. Yes. Continue.
Anthropometry, weight is 6.73 kg, is 7.1 kg, between 0 and 90 standard deviation, percentage is 95%, length is 6%, 0 standard deviation, exercise is 42 centimeter, which means 0 and 91 standard deviation. Weight for length is between 97 and 92 standard deviation.
Okay.
This one is the video baby. In supine position. When examining the baby position, like lower limb movement is continuous kicking movement is there. Continuous kicking movement is there, but like a hypotonic a baby only with the upper limb like,
Yes, upper limb movements are very minimal.
Shoulder. And elbows are flexed, elbows are extended, but lower limb movements, like kicking movements, are better compared with the upper limb. This one is baby in prone position. On prone position. The baby is trying to hold head above the couch, but only like minimal lifting there. Not like a 5-month-old baby. He's not able to hold his head and chest above the couch.
Head is only 4 weeks. Head power is only 4 weeks.
And,
What about the upper limb?
upper limb is flexing. Flexion is there.
Okay.
Flexion is there.
Is it a proximal or distal muscles which are more affected? See.
Proximal muscles.
Proximal is more affected. Seems to be proximal more affected. In the lower limb also, proximal is more affected. The child cannot move. Distal movements are better than the proximal movements. Yes. Any intercostal diaphragm involvement? Any paradoxical respiration?
No,
It is not clear.
no paradoxical respiration. No.
Which is affected in SMA? Intercostal or diaphragm?
Intercostal muscles will be affected.
Intercostal or diaphragm, which is more affected in SMA?
Intercostal muscles.
Yes, diaphragm will be relatively spared. What about the facial muscles? That also is less affected in SMA than in myopathies. More in myopathies than in SMA. Facial muscles. Okay. How will you test for the paradoxical movement?
By splinting. By splinting.
You have to test the intercostals and the diaphragm, both. How will you test?
For testing diaphragm, we have to splint the intercostal muscle. If you look for the buzzing of.
Not clear, not audible.
To test the diaphragm, we have to splint the intercostal muscle.
Okay, developmental assessment. You have to splint the intercostals and check for the abdominal movements. Abdominal should move out with the respiration. If it is moving with the inspiration, that is a paradoxical movement, diaphragmatic paralysis. Okay. Then you press the diaphragmatic area, restrict the diaphragmatic movement and see the chest expansion. Okay. Developmental assessment. Yes, continue.
In supine position, spontaneous like lower limb movements is more present than the upper limb movements, and posture is like a like hypotonic baby, and pull to sit, partial head lag is present with back rounded. Vertical suspension, no slipping through is present at present there is no slipping through. Ventral suspensions, baby is not able to hold head at the level of the trunk, and prone position only momentarily head lift is there. So only developmental age corresponds to 1 month, since only momentarily head. So developmental quotient is around 20.
Why you mentioned ATNR plus? ATNR plus, what is its significance? ATNR present.
No turnover, I think.
When should ATNR disappear? Any persistence is abnormal?
ATNR is.
What ATNR is abnormal? If it is persistent, it is abnormal. Persistent means more than
6 months.
6 months. Or what ATNR is abnormal? It's lasting more than 60 seconds. ATNR, prolonged ATNR, that also is abnormal. Even in before 6 months. That is obligatory ATNR. Yes. Dr. Sri Lakshmi said at obligatory ATNR. That is called obligatory ATNR. And its persistence beyond 6 months and obligatory ATNR both are abnormal. Just the presence of ATNR at 5 months doesn't give any meaning. Okay.
Child able to hold toys with both hands and interested in surroundings and interacting with the mother well. Child is alert to sounds and able to look at the colorful objects and plays with rattle. So fine motor, vision, hearing.
Is the baby can raise the hand above anti-gravity and reach for objects? I
Yes,
don't
sir.
think it is possible. From the video, I don't think it is possible.
If we
If
are
you give an object in the hand, because the distal powers are normal, the child will hold, but will not raise the hand and will reach out for an object which is showed in front of the supine child. I don't think the child will raise the hand. I'm not sure. Have you any video of that?
The first film itself shows the extended hands. So hardly lifting.
Yes.
First photograph.
Yes, yes, sir. Yes, sir. Yes, sir. Okay. That is doubtful. Yes. Interested in surroundings. Okay. Yes. Amel Tyson angles. Yes.
adductor angle is 70, the popliteal angle is 110, and dorsiflexor is 70 degree, and elbow reaches the midline. So all the angles are normal.
Elbow reaches the midline. Only midline.
Sir, it can cross the midline actually.
3 to 5 months. Can normally cross the midline, and when there is hypotonia, it should reach the axilla. That I am doubtful. Think about that examination findings. Yes. From the posture of the upper limb, it is unlikely. It's more, should reach the axilla. It's more weak, more hypotonic. So there is hypotonia and, hypotonia you have not examined. Yes. Yes. Any fasciculations you have not mentioned about in the general examination, any fasciculations of the tongue?
No, sir, no fasciculations.
No fasciculation. What is the equivalent of fasciculation? Not possible in this child, it is an older child. What is the equivalent of fasciculation in the hand?
Fibrillations.
Polymini myoclonus. Mild movements of the fingers. Polymini myoclonus. Polymini myoclonus. That not possible in this age group, infantile age group. Yes. Continue.
Serious examination, inspection, apical impulse is not visible, tracheal position appears in midline, precordium normal, no other pulsation seen, no scars, palpation, apex weighted fixed intercostal space, 1 centimeter lateral to midclavicular line, no thrill, no parasternal heave, no palpable pulsation or any epigastric pulsations present. Percussion, right heart border corresponds to 1 centimeter lateral to right parasternal border, and left heart corresponds to apex of the heart, and left second intercostal space is resonant.
Wait. Left heart border corresponds to the apex. No, left heart border, how can it correspond to the apex? Left heart border is from the second intercostal space to the apex. Your apex is in the sixth space. It is not corresponding to the apex. That statement is not correct. And what is the importance of right heart border? Usually is at the sternal border. It is 1 centimeter lateral to the sternal border. What is that?
Probably be a cardiomegaly.
Which part of the heart?
Right
atrium, left atrium, right ventricle, left ventricle, aorta, inferior vena cava.
Right atrial enlargement.
Right atrial enlargement. Okay. But what is the fallacy? 5-month-old baby, it is difficult to percuss. Very difficult to get a 1 centimeter lateral to right heart border. It's very difficult. Okay, so I am not giving that much importance to that. Yes, examination.
Auscultation, S1 is normally heard in all areas. S2 is normal with normal split. It's a grade 2 short systolic murmur over the apex region is there.
Okay. Any epigastric pulsations in the percussion, in the palpation?
No, sir. No epigastric pulsation.
So then right atrial enlargement is unlikely without epigastric pulsations. So what is the chamber which is predominantly affected?
Left ventricle.
Downward, outward apex, left ventricle is predominantly affected. What is your interpretation about the grade systolic murmur of the apex?
Sir, it can be a at the apical region. The murmur is usually at the mitral area, so it can be due to abnormal valve or through abnormal flow through that region. So, valve.
Regurgitant, mitral valve disease, regurgitant. Any regurgitation can occur in myopathy, cardiomyopathy.
Yes, sir. It is possible in cardiomyopathy due to the abnormal anterior systolic motion of mitral leaflet.
Okay. Which cardiomyopathy is possible in GSD?
Glycogen hypertrophic cardiomyopathy is
Hypertrophic cardiomyopathy. Yes, that is where is the systolic anterior motion. Which cardiomyopathy is possible in myocarditis? That is viral myocarditis.
Dilated myocarditis.
Dilated cardiomyopathy. Okay. Yes. Yes. Usually in dilated cardiomyopathy, murmur may not be there. Yes, here there is a murmur. Then why you examine the cardiovascular system first? There is no cardiac failure symptoms, no short cycle. It's a predominantly your examination finding suggestive of a neuromuscular involvement. So why you examine the cardiovascular system first? Is it CNS examination or cardiovascular system? That is first. It should be done first. CNS examination. So in the family history, you should show the pedigree chart. Here the CNS examination first. Yes.
Coming to central nervous system examination, baby is alert and playful. Supine position, baby's posture is supine with upper limb extended at the side of the trunk, and lower limb flexion is there and spontaneous kicking movements was there. And tone, all the forelimbs have hypotonia with deep temporal reflex is normally present in all the forelimbs.
The baby, posture of the baby, you have to explain a little more. What we have seen in the video, you have to explain. It's the explanation of the CNS posture is not correct.
Upper limb extended at the side of the limb. Then like no a turnover movement is not present. Lower limb is flexed and spontaneous kicking movement is present.
Okay. That you can describe. That has to be described. This CNS examination, the description of the posture is not proper. That you have to describe a little more after the video. Only the video is self-explanatory than the description. Okay, tone hypotonia in all four limbs. Deep tendon reflexes are normal in four limbs. Okay, now is it SMA or is it myopathy?
Hypotonia is there.
SMA anterior root nerve all is out because reflexes are absent. Here the reflexes
present. So
present.
So
or diminished. Early in the muscle diseases can be normal. It can be diminished also. Absent only later in muscle diseases. Okay. Yes.
Bilateral pupil equal and reactive. Fundus appear to be normal. Extraocular movements, like baby is able to look on the both sides when we are showing any colorful objects.
Okay. Extraocular movements in which all myopathies will be abnormal?
Nemaline.
Yes, Nemaline road myopathy. Yes.
Central core myopathy.
Central core myopathy. Yes, there is ptosis and extraocular involvement. What is another problem of the central core myopathy? Clue is rhino-rain mutation. Malignant hyperthermia. Okay, not important for this. Then any other myopathy? There is eye involvement. Mitochondrial. There is eye involvement. And then myasthenic syndrome, myasthenia and congenital myasthenia or acquired myasthenia, antibody mediated myasthenia, there will be muscle involvement, extraocular involvement. Yes.
No ptosis or no skin. Facial movements appears normal while rest and crying position. Uvula appears in central position. Tongue appears normal. No macroglycosia, no fasciculations or no atrophy.
Any hypertrophy?
No macroglosia. No.
Yes. Yes. Tongue is a little. There is a tongue thrust seen in the picture. In the photo, there is a tongue thrust, inverted V-shaped mouth, tended mouth, and the tongue is seen little protruded. Okay. Yes.
Next. Abdominal examination. Inspection. Abdomen is not distended. Umbilicus normal.
What are the positive findings in the abdominal examination? Because the time is. How much time, Suresh? How much? When will we finish? When should we finish?
9:15, sir. 9:15.
Okay. So, can you summarize the abdominal examination positive findings in the abdomen?
Per abdomen examination on palpation, liver 5 centimeter below right costal margin, a span of 8 centimeter, and spleen also palpable.
Okay.
Other
Liver is a firm liver. Okay. Hepatosplenomegaly. Yes.
Respiratory system examination, respiratory of 30 with abdominal thoracic. Chest wall is symmetrically movement. No paradoxical respiration is there. No added sounds like this. It's normal.
What is the explanation for hepatosplenomegaly? Firm liver, firm spleen. Is it due to chronic congestive cardiac failure?
Congestive cardiac failure? No, sir. Like congestive cardiac failure, usually splenomegaly will not be there.
Yes, we are not expecting a firm liver by this time. Okay. And also you have no other findings, no tachycardia, no tachypnea, respiratory system examine. Yes. No added sounds. Yes. And firm liver and firm spleen. What is your interpretation?
Firm liver and firm organomegaly in the setting of myopathy and cardiac
storage.
condition.
Myopathy is a storage disease associated with a metabolic problem. Yes.
So diagnosis is a isolated gross motor delay with normal reflexes. So hypotonia.
Gross motor alone, it is fine motor also. Proximal limb anomalies are also there, not neck alone. Okay.
Since there is absence of dysmorphism, seizures, and global development delay, the peripheral hypotonia at the level of muscle with organomegaly along with the myocardial disease. Since there is a evidence of cardiomegaly, usually it is a cardiomyopathy with not in failure, normal sinus rhythm, and normal growth. Considering the multi-system involvement with all the cardiomegaly, development delay, and organomegaly, most probably is a storage disorder. Most probably glycogen storage disease type 2. POMB will be a probable.
Srinivasan sir, tongue macroglosia, I have asked her. She said it is normal, but the tongue seems to be a little protruded. Appears to be a little enlarged, sir. Okay. Congenital heart disease. Congenital heart disease. It can be a myocardial disease or congenital heart disease. Okay. Congenital heart disease which congenital heart disease? The findings are not suggestive of a shunt deletion. Usual shunt deletions, it's in the apical murmur. That is not a shunt deletion. Congenital mitral regurgitation is extremely rare. So with the findings, congenital heart disease is less likely. It is a acquired myocardial disease acquired to myopathy, secondary to myopathy. Hepatosplenomegaly, it is a storage disease, likely to be a storage disease. Glycogen storage disease, most probably if the age is considered 5 months early age. Which glycogen storage disease 2? Which type? What are the types?
Type 1 is von Gutt.
Infantile onset and late onset. It is an infantile onset.
Infant onset only.
Infantile onset also typical and atypical are there. Atypical means it's a little slow progression. Classical presentation and a non-classical infantile onset. It seems to be, from the history, I thought it is a non-classical, but after examination seems to be a classical infantile onset. Myocardial involvement also is there. Cardiomegaly is there. Okay. Yes. How will you investigate?
Investigation revealed like elevated STOT and STPT, sir. STOT is 274 and STPT is 115. All other baseline investigation was normal. Like electrolytes was normal. Then
Liver synthetic function is normal, isn't it? Liver synthetic, only STPT, STOT is predominantly elevated. STPT, yes. What is that?
parenchyma is not like affected, and synthetic.
Okay. Storage is in the reticuloendothelial cells. Yes. Protein also is, synthetic functions are normal. Which yes. The hallmark of a myopathy is hyperechemia, hypercyclemia. Creatinine kinase elevation. Yes, that is elevated. LDH also is elevated.
22 it is elevated, and
metabolic
blood gas was done.
Yes.
So pH is 7.42, which by the
yes,
PCO2 is 30.
normal. Blood gas is normal. Yes.
And USG abdomen was done. Liver span of 8 centimeters, normal echo texture.
Yes.
And spleno size 7 centimeters. It is shows us splenomegaly at this age. This is the chest X-ray of the baby. The AP view with the cardiomegaly is there. The CT ratio 65%.
Okay.
And most probably the angle between the that left border and the diaphragm is appears like obtuse, so it is left ventricular enlargement. And also right side also we have that it crosses more than 3 intercostal space.
Not a downward, it's a broad apex, not a left ventricular type. Okay. Yes.
Right side also we have that the border crosses more than 3 intercostal space. So right atrial enlargement is also.
What is right X-ray wise? When will you say right atrial enlargement?
Right atrial enlargement more than 1/3 of the
right atrium should occupy more than 1/3 of the right hemithorax. It is not more than 1/3 of the right hemithorax. In the last 3 intercostal spaces, it should occupy more than 1/3. It's not that much occupied. So heart is globularly enlarged. Okay. Yes.
Otherwise, lung fields are normal with no vertebral anomalies or bony changes.
This X-ray, when was taken this X-ray?
Yes, sir.
When was this X-ray taken? During the infection time, respiratory infection time, or after that?
No, sir. When the baby was admitted here on 20th of July.
Yes. For the evaluation of the cardiac status.
Yes. And no vertebral anomalies or bony anomalies are seen. Soft tissues also appears to be normal.
Can you describe the X-ray? Describe in the skin, soft tissues, bony cage. Then is it a AP view or PA view? Then mediastinum, upper mediastinum, lower mediastinum, each lung fields. In that order you have to describe. Okay. Lung vascularity. The X-ray is not that clear now. Oh, yes. Okay. Yes. Continue. Time, we have short time. Yes. What is the ECG finding?
ECG finding is a sinus rhythm with the heart rate of 115. P wave is followed by QRS, so sinus rhythm.
Short PR interval. Short PR interval.
0.08.
And peaked P waves. QRS voltage is higher, isn't it?
Yes, sir.
QRS voltage is higher. Yes, you read it. Read it.
Heart, sinus rhythm, heart rate of 115.
Yes.
PR interval 0.08.
Yes.
Then like
Obviously, be a short PR interval. Leave one small space between the Q and P. Yes, two small spaces. Okay, PR interval is shortened, peaked P wave. QRS is long by yes, and also broad QRS, isn't it? More than two spaces, more than 80 milliseconds. Broad QRS. High voltage, broad, short PR interval. Okay.
satisfy the
What is
criteria of
the
left ventricular
history of what?
Sir?
Any evidence of WPW?
No slurring.
No, yes, there are no delta wave seen. No
Delta wave.
delta wave seen in the ECGs now. Okay, yes. So
No.
it is suggestive of glycogen storage disease. Yes. Yes.
Echo done on.
Yes. You can skip that. Left ventricular hypertrophy. Yes.
Then we have sent a dried blood sample for enzymatic assay. And the report came as total alpha glucose is 7.83, normal is between 10 and 60, and lysosomal alpha glucose 0.35 between 4.5 and 15.
Okay.
So we have sent genetic study also
Which
sent.
genetic study you have sent? Which genetic study?
EAA
What
mutation.
study?
EAA mutation. GAA mutation, the chromosome 17q.
Sequencing. Sequencing.
Sequence.
Okay. How will you counsel the mother?
Counsel the mother regarding the genetic, that this is a genetic abnormality, and the probable cause of the disease should be adequately counseled, and the available treatment option also. For us, the availability of myosin is it's very difficult actually for the myosin. Like it's very costly.
Wait. Is Gauri there? Gauri, Ashwati or Ansha there? Anybody try? How will you counsel the mother? Counseling is also important now.
Yes, sir. Sir, regarding the course of the disease, that it is a progressive disease.
First, you have to introduce who are you. Okay. And counseling should be in the language. What is the language they are comfortable? You have to say in the language of the parents. Okay. Then. This is first child also. Non-consanguineous marriage, first child.
Without agonizing them, we have to explain the nature of the disease. First of all, explain due to what it has happened in a simple language.
Yes.
A simple formal language.
How will you explain? Yes.
ഇതൊരു ജനിതകമായ രോഗമാണ്. ഹൃദയത്തിനെയും മസിൽ പേശികളെയും ഒക്കെ ബാധിക്കുന്ന രോഗമാണ്. ഇത് അടുത്ത കുഞ്ഞിനെയും ബാധിക്കാൻ സാധ്യതയുണ്ട്. മാത്രമല്ല ഇതിന് ഇപ്പോൾ ചികിത്സാ രീതികൾ അവൈലബിൾ ആണ്. കുറച്ച് അതിന്റെ വിലയെ പറ്റി, കോസ്റ്റ് ഓഫ് ദ എൻസൈം റീപ്ലേസ്മെന്റിന് അവൈലബിലിറ്റിയും പറ്റിയും അവര് കൗൺസിൽ ചെയ്യും. എന്നാലും we have to explain about the poor prognosis of the disease. Despite of the enzyme replacement, there is a high chance that child can have
prognosis and also better prognosis if this drug enzyme replacement therapy has a good prognosis. That will revert all the cardiac malformation, cardiac symptoms and muscle symptoms. Everything will be reverted. Okay. But that is costly. Yes. Otherwise, there is no. Now the disease has not that much affected the heart, little affected the heart, little affect the muscle. You cannot give, we have to give a little hope also. Cannot depress their hope also. There is treatment, but the treatment is not, you have to continue the treatment lifelong. It's a little costly treatment. About the cost also you can mention.
Yes, sir.
And some options for getting the treatment. There are so many options. How can you get the cost, compensate the cost? How can you get what all benefits from the community you can get? That also you can discuss to give the hope. Then how will you proceed? That also you have to discuss with the parents. If this child is affected, what is the chance for affecting the other child? Naturally, they will ask.
25%.
How can you say both parents are normal? There is no clinical symptoms. How can you find out they are carriers?
We have to do a genetic.
Carrier testing, genetic testing. Yes. If both are affected, then there is a chance for 25%. Yes. If one has Pompe's disease, and the mother is one parent is a carrier, one is affected, then what is the chance? 50% chance. Both are carriers as this. Here the parents are normal, so there is 25% chance, 50% chance for carriage, and 25% chance for normalcy. Okay. How will you? If they are not carriers, both parents are carriers, not carriers. What is the chance? How will you explain this? Can it affect
Individual mutation.
Yes.
Transformation.
Yes. If one is affected, only one parent is affected. One parent is mother is a carrier, father is not a carrier. It's an autosomal recessive disease, isn't it? Most of the metabolic diseases are autosomal recessive. Yeah, only few are X-linked recessive, X-linked dominant, and autosomal dominant. Only very few that you have to know. You should know. So it is an autosomal recessive. If one parent is carrier, can the child affected in what way? Okay. Next pregnancy, that is by what is uniparental disomy?
Uniparental disomy means deletion of chromosome material that received from one parent, and
Both chromosome material from one parent.
one parent.
Pre-zygotic or post-zygotic, both can occur. What is genomic imprinting? Okay, read genomic imprinting. How will you, next pregnancy, how will you affect the whether, how will you detect the baby is affected or not?
Prenatal testing.
What testing?
We can test chorionic sampling.
Chorionic sampling is or
amniotic fluid.
Is non-invasive technique that is cell-free DNA. Cell-free DNA, non-invasive. Can it be possible? No, because this non-invasive is not that reliable. So either chorion villus biopsy or amniotic fluid aspiration. The amniotic fluid cells, this genetic study as well as alpha glucosidase level also can be studied. Yes. Genomic imprinting is when one parental gene that is suppressed by methylation, stamped or suppressed by methylation. So only abnormal gene will manifest. Okay, both ways, when only one is carrier, baby can be affected. Uniparental disomy or genomic imprinting. Then both parents are carriers, then 25% will be affected. Yes. Or it is a mutation. Yes. Yes, stop. Can we finish? Shall we finish? Suresh? Stop. Thank you. So the topic is open for discussion. Purushothaman sir, Srinivasan sir, you can ask. Please ask.
I have been sending you messages in the chat box. I didn't want to interact directly.
Yes.
But she presented well and did a good job.
Comments.
And excellent video presentation and illustrations are very good. Yeah.
Purushothaman sir, questions?
Thank you, sir. Mamata, first of all, and all the PGs, when you are presenting, come prepared. Ensure that all your audio visuals are intact because you are talking to a group and there should not be any delay. Ensure that the presentation won't take time. Delay should be avoided. All the PGs coming for the presentation next time onwards. Ensure that part. It's very important. Then, I was listening to the presentation from the beginning. Only when you mentioned the disproportionate the development, isolated ghost motor delay, I was considering it was a cardiac problem presenting a little late. That was my impression. So in the history presentation, when you're presenting rather than the dates, that's a little bit confusing. The present with which day of the baby rather than the dates. So it is born to a non-consanguineous marriage with an adequate weight and all the neonatal period were all normal. So what we were interested in that situation where the baby was referred with a cardiac problem, suspected cardiac problem. That keeping in mind, what was the time of onset of the problem? That is very important in whatever way. In a cardiac problem, we are interested because the most of the structural problems with the failure and recurrent respiratory infections usually present somewhere up to 8 weeks before that period. Usually after this 4 month, it's a very unlikely for the shunned lesions of moderate or severe situation. So acquired this good weight gain till then at 5 months onwards, it's presenting a bit unusual. So that is a paradoxical situation. Congenital heart disease, left right shunt or increase of flow state is very unlikely to have a very good weight gain up to 4 months. And so that was a bit unusual. So even if at that period when I was considering a cardiac problem, the cardiac problem, if at all, must be an unrelated thing, and the recurrent respiratory period problem must be viral infection triggered V's or a pneumonia that period. There, when you're presenting, the full spectrum of an ARI program should be there. What about the feeding? What about the sensorium? All these things, just like an ARI control program, that spectrum should be presented. In this baby also, the feeding is very, very important because multiple ways. Because cardiac problem, the sacral cycle starting from the onset was very important. The other thing, when you say muscle problem, especially the morning to evening variation. So sucking is the main exertion. So what about the sucking? Are they choking between this period? All are important because the time of onset of the illness is very important. Let it be a muscle problem or a type 1 or 2, whichever is SMA. The onset, if it is present from newborn period onwards or a little early. So 3 reasons by which the sucking feeding is very important. One thing is to decide about a cardiac thing. Second thing is about the type of SMA, if it is motor unit disorder. Third thing is the muscle disorder, what is the time of onset. So in this case, the initial 2-3 months was all right and then only started. There again, when the development was suspicion of a paradoxical motor type of unit type of delay, so possibilities comes as a peripheral disorder. The peripheral disorder, very close disorders are the 3 things: SMA type of disease, myoneural junction disorder, muscle disorder. Myoneural junction disorder, very unlikely. So in the context when the card problem also is mentioned, of course, as Venerable sir mentioned, it is a muscle disorder per se. And when you are evaluating in that case, a pedigree chart is very important, sir. Only the pedigree chart need to include other spectrum of the problems also. Need not be weakness only, because few of the mitochondrial disorders, other things can have other manifestations in the pedigree chart somewhere. So consider that also in the pedigree chart. In the examination, very important, the ocular movement, that is the commonest of the situation, ocular movement and the tongue and the facies. So here in this case, ocular movements are spared, tongue is not that affected because those are the combinations. And the upper limb, lower limb disparity is significant, And there, one thing you missed was the hip movement. Barlow sound, autolinis test need to be included. And if it is a male child, undescended testis, the testis descended or not, and the autolinis are included in all the case of muscle disorders. Very, very important thing. The other things in the general examinations are covered. I'm not convinced, as Virendra sir said, about the reach and all, because the upper limb seems to be very flaccid. The power seems to be very small. So very unlikely that the baby will be coming and holding it. And the lower limb reflex I mentioned normal, that also a bit unusual. Lower limb reflexes present is very likely, because there are two possibilities when there is a the proximal weakness. Either it is a myopathy or neuropathy SMA. Both will be having the distal power comparatively spared and proximal involvement. There, the differentiation is basically the reflexes. Absent reflex is SMA type and presence of reflex, but it will be sluggish. Perfectly normal reflex, a bit unusual. The tongue also, you said this thing about the liver part, and you didn't mention about the JVP. When there is a cardiac enlargement, this sort of situation, two things you forgot to mention. One is the JVP. Other thing is, in the heart sound, what we expect is the first sound muffled, second sound muffled, and the third heart sound also important. Because here in this context, we are considering myocardial disorder. There, the cardiomegaly and hypo, because the periparadox, the LPSH or falsetting chest are not you are expecting, the apex you are not expecting, but the third heart sound and the muffling are the more important thing. JVP is important. Liver enlargement is I suppose it was a liver isolated enlargement. Congestive failure is need to be considered, but in this case, basal crepitation shouldn't mention. In this case, left congestion evidence in the clinical examination, basal crepitation, right-sided JVP and the liver. In the context, liver and spleen is important in the enlarged. Likely that it is a storage disorder rather than the failure. There again, when the spleen is present, is it supporting Pombe's is a bit unusual, because Pombe's, this much of spleen is a bit unusual. So that is a little bit doubtful. So the other things are all good presentations. Okay, ma'am.
Thank you, sir, for your kind words. Thank you, sir, for your explained detailed review of that case presentation.
Srinivasan sir.
Can I make one comment?
Yes,
Yeah,
sir.
if a mother is very alert, she'll be seeing whether any startle movement is there, or shouting, or closing the door, etc. That will tell early onset of myopathy. So I'm sure Kerala being a literate state, most of the mothers are alert, and then they will tell the child is not kicking the limbs and the hands are kept extended. They would have definitely noticed it. You are very correct, Dr. Purushottam. Which had come first could have been identified by a little more history about the child's behavior, especially kicking behavior of a normal full-term child. Thank you so much. It is a very good discussion, very interesting case, and we learned, all of us learned. Thank you for allowing me this opportunity to listen and learn. Thank you so much.
Thank you, sir.
Darling, madam.
It was an excellent, extensive discussion actually. Virendra sir has done it very well.
Really an extensive discussion, including CVS and neurology.
Yeah.
And including a bit of genetics also.
Yes.
It was really wonderful.
But the splenomegaly, I am surprised, because the gas shadow of the abdomen, that stomach was very well seen. There was no evidence of this thing, shadow.
Yes, sir. Yes, sir. X-rays doesn't look like a splenomegaly.
Probably it is supine filling, sir. Probably it's a supine filling. Because the baby was in the ICU and we could take only a portable X-ray. Finally, Mamata is visible.
Yes.
Mamata, you should have switched on this video, because that would have been more lively during the presentation also.
Your video was not there.
Unknowingly switched off, sir. I didn't know it. At first, I switched off on the video. I don't know. I didn't know why.
You were not visible throughout the presentation. Only now you came to the timeline.
I was unaware of that.
Initially, she was there. Initially, starting, she was there. Later, of course, she.
Some technical issues was there at that time. Video went off. I didn't know.
Now it's very clear.
Well done, Mamata, well done.
Okay, thank you, Virendra sir, for that detailed discussion. Thank you, Srinivas sir and Purushottam sir for joining the discussion again. And again, hats off to Mamata for the good presentation. And we'll, with no more questions, we'll end the session. Thank you all.
Thank you.
Thank you. Sir. Good night.
Good night, all of you.
Good night, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Hello, hello.